Good morning, everybody, and thank you very much for joining our SPHN webinar. Today, we will hear about the driver project SwissHEART Network. This is a project funded jointly by SPHN and PHRT in 2018. In the realm of this project, a variety of different data types, so for example, clinical data, laboratory data, electrocardiogram, and imaging data will be collected of patients at risk and patients hospitalized for acute heart failure. And in the SPHN funded part of this project, a Swiss-wide standardized data infrastructure focusing on typical cardiovascular patients is being built. So this is the Swiss Heart Failure Registry. In the PHRT part of the project, multidimensional features from these patient data will be integrated into machine learning-based approaches. We are now very curious to hear about the progress of this project. And with this, I would like to welcome our speakers of today. This is Professor Christian Matter. Christian is a professor of cardiology at the University Hospital in Zurich. Professor Joachim Buhmann. Joachim is a professor for computer science at the Institute of Machine Learning at ETH Zurich. And Dr. Antje Thien. Antje is a project leader at the Research Data Service Center at the University Hospital of Zurich. So I'm happy to pass the word to you now. Thank you very much for taking the time and being with us today. Christian, I think you're the one who starts, right?
Correct. Thank you very much, Katrin. Thank you for the opportunity to present to SPHN and PHRT. And a big thank you also to Joachim Buhmann and Antje Thien to participate in the presentation today. Welcome, everybody. I'm very happy to give you an overview what we have been working on in the past 2 years in our Swiss Heart Failure Network. As you can see here on the screen, our Swiss Heart Failure Network is a Swiss-wide standardized way to collect clinical data, to build a network of patients hospitalized for acute heart failure or acute coronary syndrome. And as Katrin said, it's a driver project, SPHN side, myself and the main applicant, together with the ETA PHRT side, where Joachim is the main applicant. We're happy to cover the following topics. I give you a little bit of background about cardiology, touch on machine learning that will be expanded by Joachim. I will report the research aims of SPHN and PHRT. Antje Thien will go more in detail into IT infrastructure. Joachim will then present the machine learning part and the third aim that we'll come to. He will then back over to me. I will report the achievements within our driver projects, the lessons learned, the perspectives, and follow up with a conclusion and take-home message. Our Swiss Heart Failure Network is a Swiss-wide consortium that has 4 cardiologies: Geneva, led by François Mach, where Christian Lovis is evidently the expert with interoperable structured data; Bern with Stefan Windecker and his crew, where André Frank has been a very crucial member and contributor to our network; Basel, headed by Christian Müller, with his colleagues, and in Zurich, it's myself with Frank Ruschitska, the head of cardiology and associates. Joachim Buhmann is at the ETH and has his group there that drives the machine learning and big data analysis part. And of course, I should also mention a big thank you to SPHN for funding our project with 1.48 million over 2 years. We very much appreciate that. Now, what is the relevance of acute heart failure? Why did we embark on that particular subject? It is very frequent. The occurrence of heart failure worldwide is estimated to be about 22 million people. The phenotype and the drivers are multiple. It's a typical syndrome. It has many triggers. It starts with genetics and genetic alterations. Cardiovascular risk factors play a role. The causes can be valvular or ischemic heart disease. That then leads to molecular, cell, and structural changes, resulting in the end in an impaired heart function and insufficient cardiac output. That is the common denominator of acute heart failure, a multifaceted syndrome, as you can appreciate here, that we want to look at more in detail. The risk prediction is very difficult, as it is this syndrome with many facets. Attempts have been made to base risk prediction on the left ventricular ejection fraction, EF, whether it's reduced, as you can see here, with heart failure with reduced ejection fraction, HFrEF, with a mildly reduced ejection fraction with preserved ejection fraction. But risk prediction evidently is still under development and needs to be improved significantly. So there is a great medical need that we can address if we want to understand and treat that better. Now, the big challenge evidently is also that the data about acute heart failure are very heterogeneous. The collection accordingly is very time consuming, and the analysis, given this multifaceted phenotype, is complex. An ideal setting, we think, to embark upon that and look at it more in detail. That's why we felt that we have to look at the Swiss Heart Failure Network and specify that. We have two main syndromes we want to look at here. It's the acute coronary syndromes and the acute heart failure, the other syndrome. And what we evidently want to look at here, look at all the risk factors, symptoms and signs, particularly look at the EKGs and the echoes, look at in detail about the biomarkers and the drugs that will constitute the baseline. Now, the beauty of both acute coronary syndromes and acute heart failure is they converge, because a big infarct following acute coronary syndromes may result in heart failure. That's why we have these common outcomes, that is death and heart failure hospitalization as a primary endpoint that we want to look at. So all these parameters at baselines, multifaceted, as said, will be linked to an outcome. In acute coronary syndromes, we can look at the prediction and prevention of heart failure, because that may just occur when a patient has an acute coronary syndrome. In a patient hospitalized mainly for acute heart failure, we look at the progression or regression, respectively, of heart failure. So that is the setup of our study. Now, machine learning, what has been done in cardiology goes very quickly, and there were major advances as EKGs and echoes are the focus of our analyses and raw data analyses. I can show you here a couple of publications where automated echo analyses can be done. Evidently also EKGs analyses published very well, as you can appreciate here, and machine learning based prediction of adverse events after ACS have been just, you see the two publications very recently this year have been published as well. So the field is moving very fast. Now, what we want to do is to apply machine learning in our specific context with acute heart failure and acute coronary syndrome. We want to fine-tune disease classification and perform a risk stratification. For that, importantly, we have to rely on standards. We want to understand the contribution of risk factors of the triggers, get insight into mechanisms, and particularly collect the raw data of EKGs and TTs. This should also allow us to get insight into the drivers of the disease, selection of optimal drugs and outcome. This, as said before, should improve the prediction and prevention of acute coronary syndrome and decrease in the end the progression of acute heart failure. At a personalized medicine level, we want to assess the individual patient's baseline and response to therapy and predict outcome, meaning in the end, we want to both improve and individualize the patient management. That was the basis for creating our Swiss Heart Failure Network, where we have the following key research aims. As part of aim 1, that is part of SPHN, we want to build infrastructures. That has to be done in a Swiss-wide fashion, has to be standardized, and following the ethical and legal standards with the identification. Antje will specify that more later on. We will also, as a second aim, build the Swiss Heart Failure Registry, where we want to collect big data, electronic health records, and collect the raw data of EKGs and transthoracic echocardiograms. The idea was also to build a biobank. And Joachim will detail about the PHRT aims, aim 3, apply machine learning tools in these particular patients. So let me start with the first aim, infrastructure, and give you a glimpse before Antje takes over. We evidently want to build an infrastructure for our purposes. For that, we have the primary data of the patients, the clinical information, the echoes, and MRIs, the imaging data, EKGs, and labs. That will flow into the system. Antje will detail on that. The clinical information evidently is key, that we specify the present illness and get as much as possible our automated data extraction. That is possible from vital functions and probably not that much from the physical exam. The drugs are available in a structured fashion. We aim to get the TT raw data, EKG raw data. That's very easy there because it's a highly standardized test. And the lab values are also available in a structured fashion. So we have a good deal of collecting the data here at the patient level in a structured fashion, which evidently will save us on manpower. But the key thing is not all of those parameters that are key and will determine diagnosis and prognosis in the end are yet available in a structured fashion, and it's not the same Swiss-wide. So one of the key tasks of our project is to streamline the processes for automated data extraction, local and Swiss-wide. I come to the second aim very shortly to set the base for a detailed look at the infrastructure. So one of the goals is the building up of the Swiss Heart Registry. For that purpose, we want to look, as I said, at two facets of syndromes, acute coronary syndromes, acute heart failure. We estimate that roughly 5 and 300 can be collected at each site, and depending on how many years we'll go back, we will collect Swiss-wide at our 4 institutions a couple of thousand patients that will yield a sizable number of big data. Primary endpoints, given the focus of our project on heart failure, is heart failure hospitalization and death. I already specified the key research goal for acute coronary syndromes, that is prediction and prevention of heart failure. And with patients that have acute heart failure, it's progression and regression, if possible, of heart failure. A key goal is to collect structured Swiss-wide data from acute heart failure and ACS patients. We had the following stepwise approach and concepts. We want to take advantage of the available data that already have outcome. For that purpose, we have collected within the special program University Medicine, sponsored by the Swiss National Science Foundation, SPHN ACS, 10 years of patient data that are available for baseline and outcome analyses. That should allow us to test the IT infrastructure. For that, we have a good head start to build our new common Swiss Heart Registry, refine the IT infrastructure, and then embark on a retrospective analysis where the advantage is that the outcome is already available, and have on the radar for the future to build a prospective standardized data collection. We already have compiled a common registry, an electronic case report form, as you can appreciate here. The primary data that I showed you before will be inserted in these ECRF, where we have evidently a look at eligibility demographics, past medical history, present illness, etc., as you can appreciate here. The key focus is, for that purpose, to have automated data extraction. That is the key. And with that, I hand over to Antje Thien, who will specify the IT infrastructure, particularly for Zurich, but with a view all over Switzerland, what the challenges and successes were in that endeavor. Antje, thank you very much for participating in our adventure. As said before, Antje Thien is project leader at the Research Data Service Center at the Clinical Trial Center at University Hospital. Antje, please.
So thank you, Christian, for this kind introduction. So I hope everybody hears me well. Yeah, so let me say that I'm very happy to contribute to this very interesting driver project, which really indeed drives important developments of the IT infrastructure. As you can gather from my first slide, the IT infrastructure that is required for the SwissHEART project, but as well for other SPHN driver projects, is quite complex. So there are really many processes which need to be set up and which need to be optimally interlinked to eventually allow for a secure transfer of a big data set, of a big interoperable data set to the biomed IT nodes where the data analytics takes place. So the processes that need to be set up include, for example, an automatization of data collection, so the collection or the export of data from the primary clinical system to the data lakes, to the clinical data warehouses, but of course also, as Christian just pointed out, harmonization of the data, so make the data interoperable on the level of your data storage, in the case as is the case for the data registry, for the SwissHEART registry. Some or other processes which are also fundamental are, of course, to set up de-identification standards and processes which allow for correct and adequate pseudonymization of the data. And finally, also a secure and very performant transfer of these huge data sets to the nodes. So today I would like to focus on two examples of development examples which were driven by the SwissHEART project, mainly on the side of the data collection, so on where the SwissHEART project really drove the automatization of the data collection. So I will not so much go into the technical details, but really like sketch the principal improvements that we were able to implement in the frame of the SwissHEART project. So one very important data type, as you have already heard from Christian, are ECGs. So ECGs at the USAT, but also at other hospitals like the Inselspital in Bern and the USB in Basel, store the ECGs in the Schiller CEMAS server. And in order to extract those data from the server and to get them to the clinical data warehouses where they could be interlinked with other clinical data, we previously had really to rely on a very tedious manual process. So a mass export of ECGs for a given cohort of patients was basically impossible. So we could export ECGs only from single patients or an overall time period. And we were restricted also in the amount of ECGs that could be exported at once. So all in all, a situation which is really not satisfying and not suitable to to answer to the needs of big data-driven projects. So next slide, please. Thanks. So in the frame of the SwissHEART project, both the Inselspital and the US implemented a process which now allows for an automated mass export that was already previously implemented in Basel at the USP. So basically, we are now in the much better situation to be able to perform an automated mass export of a list of of a given cohort of a given set of ECGs of interest. So in a first step, we are now able to perform complex queries which allow to identify the ECGs of interest in the SEMA database. So there we also have many filter options, which is of course very favorable. And then in a second step, we can enter this list of ECGs, unique IDs, or also patient IDs as most adequate as an input into an export tool that was developed by the Schiller company, and that was integrated in our environment and the environment of the Inselspital. So now we have no longer the issue with also with the restrictions on the amount of ECG that can be exported at once. So this is of course a much better situation than it was before, and we are now in the position to export ECGs of relevance for a given cohort in a much faster and more automated fashion than before. Also concerning the format of data of the ECG extraction, I would say that we made some progress. So there was quite some discussion on the most adequate export format. So it was either XML or DICOM. And as you know, one aim of SPHN is also to come up with recommendation on the preferred standard or preferred data standard for a given data type. And we eventually, within the project and among the hospitals, agreed that wherever technically possible, we would export ECGs in a DICOM format, which is like the medical imaging format, and which also leverages synergies with the second data type I will focus on next, namely the TTs, the echoes. Yeah, Christian, maybe you could. So for the echoes, for the TTs, we were basically in a very similar situation for the ECGs. So echoes at USZ are stored in our long-term archive called Synodra. And there were, of course, export options. However, again, very manual. So the export of big data sets was, again, very time-consuming and just not suitable for projects like the SwissHEART project, where we plan to export huge amounts of echoes. So here we were able to establish an extraction, the de-identification of those TTAs, which are also exported in DICOM, was not standardized previously. So there are many tools around which all do some kind of de-identification. However, the standard, there was an important lack of standardization in this regard. Okay, so within the project, the SwissHEART project, we were able to set up a possibility to perform an extraction or to really perform an automated mass extraction of not only TTs from the long-time archive, but also from all kind of different media files that are stored in the Synodra long-term archive. And the principle is again the same. So basically we can perform complex queries identifying the TTs or the media files of interest using the Synodra database, or also information from our data lake. Then in the second step, we can insert this list of patient IDs or unique IDs for the media files as an input in our extractor. And then we can basically perform an automated mass export of all those, in this case, TTs of interest. Another advantage of this, as we call it, Synodry extractor, is that it has an integrated de-identification module, which really adheres or takes into account acknowledged international guidelines on de-identification, namely the basic de-identification profile from NEMA.org. So this is, so to say, linked up on export. The files can be already de-identified in a very standardized way. However, still a project-specific tailoring of this de-identification is of course possible. At this point, I would also like to thank Alina and Fabian from the ETH, who contributed a lot to some of the aspects and the infrastructure implementation that we were able to establish in the frame of the project. And we're not quite there yet, but I think we made a huge progress, and many thanks to your contribution in this regard. Thanks.
Okay, thank you very much, Antje. I'm very happy to now share the screen. Excellent. To hand over to Joachim Buhmann, who will continue to present the AIM3 machine learning in our project. Thank you very much, Joachim.
So thank you very much, Christian, for the introduction. Switching slides is always an enterprise. I will have the pleasure to report on the PHRT aims. In particular, we pursue 3 different aims. We want to build a 4-dimensional dynamic digital heart model in a way that it's actually clinically relevant. So it's not primarily the physics which has to be modeled in detail, but extract geometric features which help you then improve diagnosis. Machine learning algorithms are supposed to improve acute heart failure diagnosis and risk stratification. And finally, we want to personalize that information to get better decisions for the patient. So the geometry should influence, in the end, the personalized treatment. So the overview of the project can be seen as this flowchart. We talked already a little bit about the data. The MRI data might help you to build this digital heart model. But equally important, you have data here from the echoes and from the ECGs. And this information, together with your sort of generic digital heart model, allows you to then hopefully personalize your model. Then you have the heart model with the geometric information. You can use that heart model, since it's now in the machine learning framework, to synthesize data, to compare them with the original data, and to further improve the modeling. But in the end, the clinical impact is what counts. And so these heart models should also give doctors a better way of analyzing the situation of the patient, and be supported by other types of machine learning features like subtype detection, survival prediction, and the interpretation of the data. So what are the challenges? Essentially, we identified 4 different challenges in this initial phase. You want to do geometric inference, otherwise you will not get geometric features for the diagnosis. These features have to be mechanically plausible, so they should be consistent from the electrical side and from the mechanical motion side. There is data misalignment, which you have to treat. So the ECGs and the echoes are not taken at the same time, so this has to be taken into account. And in particular, the question is, what does it mean that you validate in the end your results? The validation, as I said already, is not with respect to the physical appearance of the heart. It's the validation in as much as it makes a difference for the intervention of the doctor in the therapy and in the prediction of the outcome. So that information has to be isolated. In order to do that, we designed a project pipeline from data analysis to the 4D heart model and the inference. So that's basically the 3 different stages. And I will now guide you through that pipeline to highlight some of the challenges which we have and early successes. So for data analysis, first you have to remove the clutter, which is informative for the doctors, but not so much for the data analysis, which we are pursuing. So this data has to be processed. You want to have a heart chamber segmentation that you know where the region of interest is. You have to predict the heart chamber views. So you want to distinguish that, and that has to be reliably combined with the information before. And then there's the heartbeat extraction from the ECGs. And here you see some preliminary results on the end systole and diastole. I should also mention that this has been reported in publications. The data analysis further is on the echoes. So here we had a side study to identify the heart valves here, going from the initial echo data via window detection and then using validated machine learning techniques to track the interesting part here. And in this case, it's the valve. For other diseases of the heart, it might be other features which in their motion have to be characterized. Here is the data analysis for deep heartbeat. Again, the echo, you have a neural network type of processing here where you encode, and then in a temporal network, you extract the features, and the decoder then allows you to synthesize again the output, and hopefully what is synthesized here has directly an influence on how you interpret these frames in terms of segmentation. And this segmentation you see here has deficits. That's state of the art, and this is what we improve, what we improve upon. So this segmentation hopefully is then good enough for our further processing. Now the data analysis on the ECG level again uses a deep neural network with a heartbeat encoder and heartbeat decoder. The features then have to be analyzed, and what Alina, that's her project, Fabian is focusing more on the echoes. What she was pursuing in this context is to interpret the features with ablation studies. So you have a number of features, you can rank them according to their appearance. You can also cluster them in appropriate spaces. And if you then switch off some features, then you are missing that information, and you see it directly in how the reconstructions of the heartbeat then is deteriorating. Now, to put it together, to have a heart model, we need neural rendering-based models. So again, the input, you do your pre-processing and your feature extraction. And then you have your network, which converts these extracted features then in the geometry. For this type of analysis, you also have to predict the viewing angle, and then you can start analyzing particular parts of this digital heart model to give you the segmentation. You then can confirm this segmentation with looking at the original echoes and then draw your conclusion. So this is one way of achieving that. We have a second line of less discriminative, more generative analysis to build the heart model. Here you see the geometry, which is analyzed and then reconstructed here. And then we use a discriminator network, which has to discriminate between the reconstruction and the original input. And whether this network then has to make a decision, is that for real or is it fake? And that feedback signal then allows you to adapt these millions of parameters which you have in these networks. We do the same for echoes, and in those cases, you ask, was it real, the real measurement, or was it a synthesized analysis product? And this feedback signal then allows you to adjust these weights. So here, for the digital heart model, the challenge is exactly that these internal representations for the geometry and for the echoes have to be aligned. So here you jointly want to learn these internal representations such that they capture these information. Now, what is the validation all about? The question is, with much more detailed physical model, is it captured in as much as it's necessary by our digital heart model? That's the question. And so we identified 5 different facets of this validation. First, we want to improve heart failure diagnosis. Is it useful at all in clinical practice? The second one is it plausibly from a mechanical point of view? Ejection fraction would be a measure to check that for this model here. Then you can do synthetic data generation and ask the doctors whether that looks plausible or not, or automatically make the comparison. The evaluation by the doctors also help to guide the learning process better in a direction so that the clinical relevance is emphasized. And at the very end, you know, you might have surrogate ground truth models coming from MRI or either any other type of analysis technique which gives access to the geometry. We think about all these components, but due to currently still the lack of data, we have to focus on what we can do on the available data. So the TTE diagnosis, here you have your input and the segmentation. You extract then via these network, the time series. That's what you basically get from this analysis. And then you have at the end a network which gives you the risk stratification. So 80% TTS and 20% acute myocardic infarction. So that was a Takotsubo study where we used this type of pipeline to show. The same has been implemented for the ECG diagnosis. Again, as I said, you have this encoder-decoder setting for reconstructing your heartbeats that allows you with the internal representation and the extracted features to do a classification. And here you see on an extensive study with ECGs, we reach over 90% of these of precision for these categories of different heartbeats. So what are the next steps? We want to personalize this 4D heart model. For this, we need much more data, which we are still waiting for. We want to have this 4D heart model for heart failure diagnosis and risk stratification, as I pointed out in the beginning. And then there are typical questions like, can we actually subdivide the patient collective, the patient cohort into subtypes, both based on TTEs and the ECGs. And we have ideas how to proceed, but this is still to come. And with that, I hand over the word to Christian, who can give us then the summary and the wrap up of this project.
Thank you very much, Joachim. That looked marvelous, and I'm looking forward to sending you the next package of data. Come to the achievements of the whole team. For AIM-1, we have created an IT infrastructure, went through agreements. We have, as heard by Antje, worked very hard on the local and Swiss-wide IT infrastructure, have established that, have signed many agreements, have gotten ethics approval, not only for the retrospective and for the SPUM extension, but also have already written a prospective proposal. For the AIM-2, we have built or are building a national Swiss heart failure registry. We have created a common ECRF that I've shown you, focusing on retrospective analyses of both patients with acute coronary syndrome and acute heart failure. We're mapping an IT path for automated data extraction, going from clinical to research. And we have, as elegantly shown by Antje, extracted raw data, TT and EKG data that build the core of our analyses. And Joachim has very elegantly shown how ETH does the analyses in that regard. And we also have identified control data sets where we look at normal TTs and EKGs. That should be valuable to see the difference to the diseased types. And we're very happy to have the collaboration with the machine learning experts at ETH, with your group and your colleagues, Joachim, and look forward to data delivery to you very soon. Now, what are the lessons we have learned? Personalized cardiology is an attractive vision that needs a lot of expertise, but also needs budget, time, and patience, we learned. Interoperability is in the federal Swiss system a big issue. The IT infrastructure in Switzerland is very heterogeneous, and we have to go step by step. We learned that many agreements have to be signed to make sure that collection data transfer of the big data goes legally and ethically sound. Communication within the project to achieve the common goals is an issue, and between the projects, different projects as well. We evidently have to learn from others. But overall, we think these are feasible common goals if you go by small steps, stick to timelines, control and improve. And that's why we ask for a project extension and are happy that the SPHN approved that one. All the challenges can be addressed. And as you can see, the driver project in 2019, difficult path, low vision, goals not so very clear, but today we're all going in the same direction and the vision is clear and spring is coming, so less snow anyway, and easier catch. The timelines, we spoke to you about the ethics and agreement IT that has mainly been addressed. The SwissHEART Common Registry is something we have invested substantial time in making a CRF, common CRF, working on server, etc. We will start with retrospective patient inclusion very soon and are already working on the available SPOON data, as I said. And the machine learning-based analyses are ongoing with the available data and hopefully coming very soon with the retrospective data. Now, what is the impact of a successful SwissHEART for the network? We are very appealed by the perspectives. We think we have the tools for a standardized cardiovascular data collection, local and Swiss-wide. Given its interoperability, that should be a good stage for collaborations. Long term, we also think that it may facilitate a standardized routine and foster international interoperability as well. The automated data extraction from structured data will minimize domain power. We plan to embark on prospective data collection and also think that simplified nested studies should be possible, and that should set the stage as well for facilitating a Swiss-wide funding with the extension of our network. In the end, we think that this will increase the knowledge about acute heart failure and provide eventually a quick feedback loop to the treating doctors to improve. That's the key goal, patient management. I come to the conclusion, take-home message. At the level of interoperability in IT, we have broadly invested in a Swiss-wide structured clinical data collection, paved the data paths focusing on clinical, mainly EKG and TT, echocardiographic analyses, transfer the data to ETA, and think that this is a clearly enhanced sustainability of our network. We have excellent teams with complementary expertise. I very much appreciate we have clinicians, coordinators, IT data science experts. We also have agreement specialists, I learned, and we have the machine learning experts. The goals are to complete the retrospective SwissHEART for the registry and set the stage for a prospective data collection in real time in the very near future. This all together should create the feedback loop back to doctors and patient, and as said before, improve the patient management. In the end, to sum up, we think personalized cardiology focusing on patients with acute coronary syndrome and acute heart failure is not only an attractive vision, but an achievable goal that I'm very happy to pursue. Thereby, I wanted to thank all the teams that provided their precious input for this network, the PIs and the chiefs of cardiology, Stefan Windecker in Bern, François Mach in Geneva, Christian Müller in Basel, Frank Roschitzky in Zurich, and also, importantly, the SPOON Consortium. The local coordinators that are key for the project, Joachim Buhmann's group at the PHRT side, particularly also Fabian Lammen and Alina there. The IT groups presented by Antje, Thien, but also working very hard at the other sides in Bern, in Geneva and Basel. And last but not least, I would like to thank Katrin Kramery, SIEB, Biomed IT, and the whole SPHN group for their precious support. And most importantly, a big thank you for your attention.